And I see my spicy friend has hopped on. Hey, Dr. Pepper.
Hey Boo, how are you?
I'm good. I'm good. So it's funny whenever we cross paths, I'm like, I literally in the back of my mind, I go twinsies because, and we'll
Because
get
we are,
there.
right?
I know, and we'll get there to share our stories. But first, I just want to welcome you to the Love Below series. And I was just, refreshing the audience to what this whole series is about. As a colorectal surgeon, I interact with so many different specialists who most people wouldn't even believe that I interact with because there's such a complexity to specifically the colorectal and anal rectal area, the
Yep.
pelvic floor. There's so many disorders. There our body is so nuanced. The things that go into us being able to carry and bear children, to poop, to pee, to do like all of those things. Um, so we'll get into that momentarily, but I want to take a moment and allow you to introduce yourself, your specialty, and your why.
Yeah. Well, hi. Thanks so much. I'm always delighted to be with friends and colleagues. And, especially in this, we're not necessarily post COVID, but in this after COVID season, I think everyone's really desperate for connection. And there's never been a time where patients want to trust and need to develop trusting relationships with the people who are taking care of them. And we need to earn back our community's trust. And so I love that you're having these live conversations with people to like destigmatize what a lot of people don't want to talk about. So thank you for having me. I'm Kara Pepper. I'm an internist, which is an adult medicine doctor. Um, there's a lot to say about how I got here, but in short, I was, with a big hospital owned typical private practice doing primary care. And about 4 years ago, started my own practice. You and I started at the same time. And it started as an eating disorders practice, which not a lot of folks take care of in the adult world. And really, no one ever, quote, just has an eating disorder. And so it evolved into this like medically complex practice for POTS, mast cell disease, Ehlers-Danlos syndrome, and that's where you and I have a lot of overlap, interestingly. And so it's become the most fun job I've ever had. I'm learning so much every day. And it's really cool to be able to take care of patients in a way that's healing for them and healing for me. So thanks for having me.
No problem. Thanks for joining. And yeah, and so that the latter part of, how your practice has evolved is really how we connected even more. I
Mhm.
know we connected a lot early on in that kind of immediate post-COVID phase of life where we were a little disenchanted with our careers,
Yes.
given the years that we trained and fought and the things we did for our patients. But, so we both kind of transitioned on over to private practice. But then I think we both even found further niches within our niches, which has
That's
actually
right.
been interesting that we've been on a parallel path because
Yeah.
I'll tell you, as a woman in colorectal surgery, very early on, a lot of times women in this field will get a little bit pigeonholed in dealing
Yeah.
with women issues, right?
Yeah.
And
Yeah.
so the hemorrhoids, the tags, the incontinence, but there's again so much more complexity to it. And there is, as we've discovered, a whole class of patients, the
Yes.
mixed connective tissue disorder patients, the Ehlers-Danlos patients, kind of all of those things. Hey, pup. Um, that are sometimes even separate and apart from those other traditional kind of pelvic floor patients. And so
That's right.
we've
That's
been
right.
interacting quite a bit, navigating that space. So if you can just kind of tell us a little bit about those complex medical conditions that you treat and really like how they overlap with the colorectal space, the pelvic floor space.
Yeah, exactly. So I think from a high level, these are diseases that we did not get a lot of training on in medical school. And they were thought to be, oh, just like minor things that don't impact a lot of the population. And we think perhaps about 20% of the population has some spectrum of what I take care of. Um, and for those folks who don't know, this triad of like POTS, postural orthostatic tachycardia syndrome, which is an irregularity in how your nervous system and nerves, particularly of the gut, behave. So that can show up as bloating, constipation, slow transit. And then there's Ehlers-Danlos syndrome, which is a connective tissue disorder, which makes all of our tissues, not just our joints, bendy. So the pelvic floor is heavily impacted by that, trouble evacuating, bowel and bladder, chronic constipation related to that, surgical complications. Um, I will not even begin to get into the obstetric complications related to that, but that's a whole nother story. So POTS, EDS, and then mast cell disease is a kind of spectrum condition of the immune system that can cause digestive irregularities as well. And so I lovingly refer to the patients I take care of in the clinic as like this invisible illness clinic because one, not a lot of people know about this stuff. Two, the syndromes are non-specific in many ways, so no one really knows what to do with these patients, and patients are desperate for care. And so our overlap, you've called me many times to be like, I've got this patient who's been sent to me, for colorectal surgery, but what I really think they have is a connective tissue disease, and I want this to be addressed in alternative ways. And so I didn't train to be a gastroenterologist, but I spend a lot of time talking about poop in my day job, and I still remember, I'm a PGY 21 this year, meaning I graduated from medical school 21 years ago. And I still remember 4 years prior to that, as a first year med student, a colorectal surgeon coming and giving us a lecture and saying the colon is the most amazing organ. It's the best organ. And this is like an ongoing joke for your listeners. Like doctors always argue about what's the best organ.
Mhm.
Colon is the best organ because it can tell the difference between a solid, a liquid, and a gas and choose which one it wants to, release at any given time. And even the hand, everyone thinks the hand is so cool and the brain is so cool, but it can't even do those things. And so the ability for your patients to have freedom to be able to leave the house and not always be worried or trapped because they can't leave the house, people be able to ambulate and move about the world freely, for people to be able to go out to dinner and have social connection and not have to worry about how their GI system is going to behave. The colon is where it's at. It really dictates a lot of people's freedom. So anyway,
Yeah.
so you're doing a lot,
So,
right?
and to your point, because of all of those things and the way it impacts just like basic interactions, I
Mm,
find myself as a colorectal surgeon often being an internist, a surgeon, a coach, a therapist, a
yes,
psychologist, a nurse,
yes,
like just kind of all of those things because folks come, um, a lot of times in a position where they're a lot of times they're just really ready to give up.
yes,
And so when we talk specifically about, incontinence, for example, like, I had a lady that saw me the other day and she's like, I've really been battling this for a long time. And, I just thought it was because, I'm old or this and that.
yeah,
So, I buy the pads and I'm like, well, yeah, you are old. She was old, but it doesn't necessarily mean that you have to suffer. And then
yeah.
she's like, yeah, people never talk about it. And, the statistics actually show that 1 in 12 adults suffer from fecal incontinence. Like
Whoa,
fecal incontinence, that means the poop
wow,
incontinence. We're not even
yeah,
getting into the urine and kind of
yeah,
all of those things.
yeah,
And even that might still be, underreported because
yeah,
people may not be, fully honest with what's going on. So, and, as you said, I'll send a patient to you because I'll listen to their story. I mean, there's a classic syndrome of patients who might come with incontinence or pelvic floor problems, right? The multiparous or, woman, someone who had multiple babies, especially vaginal deliveries, complex birth trauma, tears, prolonged labors. But every once in a while, like I'll get a young lady who is, she may be early 30s, mid 30s. Yeah, I've had kind of constipation and gut issues all my life, but
hmm
I can't really evacuate. I can't push it out. And you do a physical exam and you feel like, you know, I have to tell you how I figured this out, but I literally put a finger in the rectum, a rectal
hmm
exam. And poor man's test, I asked them to push.
hmm
And when they push, I feel like their whole pelvis is caving in
hmm
towards me. That
hmm
should not happen.
hmm
Only certain aspects of that pelvic floor should change when it's time for you to pass your bowels. And so
yeah,
those are the folks I'm like, she's never been pregnant, she's never had a kid, never had surgery down here.
yeah,
Something's not right with their pelvic floor. And so that's where we begin these conversations about these your invisible clinic, these invisible
yeah,
diseases that,
yeah.
folks are dealing with. So, let our audience know a little bit about when you get that type of patient. What's the process? Because again, a lot of them are really at their wits' end on things. And I know when they come to you, to some degree, a lot of the evaluation and questioning has to start from scratch. So just walk us through a little bit about this process about how you just kind of develop a relationship and that kind of process with these patients.
Yeah. I think the thing that you do very well and that is clear about both of our practices is that one, we believe patients when they come in with symptoms, and we're both really curious about perhaps why they're having those. And two, we built practices that we allow us to dig a little deeper. And most importantly, we recognize that by the time patients see us, they've experienced some degree of trauma in their life as a whole, but particularly in the healthcare system. They're trying to like navigate and figure things out. They've not been believed. They've spent a ton of money and resources, and most often like years before they even find me or get referred to my practice. And so every patient that walks in the door, after we do our, formalities of like, hey, nice to meet you, I tell them that, like, I assume that you've experienced some degree of trauma. I am here in service of you. I believe you when you tell me that you're having these issues, and my job is really to help you return to what your version of health is. Um, um, some patients come because they have a problem that they're trying to have solved. They have a question they're trying to get answers to. And some people are really just there to be like, I heard you know how to take care of this stuff, but I'm not sure you deserve my trust or my time or my money, frankly. And so I'm just here to like kind of check you out and make sure the vibes are right and that this is a place where I want to move forward. And so understanding that people are desperate for answers and don't have a lot of trust in our healthcare system is generally where we start. Um, and so I'm an internist, like I mentioned. So I'm an adult medicine doctor. We're trained to solve puzzles for a living, which is like the most fun thing ever. I'm the person
Hmm.
on my dining room table that always has a jigsaw puzzle. So
Yeah.
we're trained to look at all the different organs and put the pieces together. And when someone, fills out a form and it's like, do you have cardiac symptoms? Do you have GI symptoms, skin symptoms, lung symptoms? Pelvic floor symptoms, all the way down. When patients are like, I have all of those things and I've had a lot of them for most of my life, that's always a clue to us to be like, there's
Hmm.
some sort of unifying diagnosis. Are you just unlucky
Yeah.
and you have like 10 medical problems, or is there something else that's going on? And so connective tissue disease often ends up being part of that story. So for me, it's fun to like get someone to tell their story in a comprehensive way, help them understand how to put those pieces together. And then every patient is different. Some people in my clinic are having lots of nutritional issues, and that's where they need the most support. Other people can't stand up without being dizzy. Other people are having a ton of joint pain. Other people are having a lot of allergic reactions. So every person is the compass. We delineate what are your most annoying symptoms and what is important to you. Like if you could tell your friends and family, I feel so much better, how would you know what that is? And then we
Right.
build a plan around that, because it doesn't matter what I think is right. I mean, I
Exactly.
can give people advice, but like I want them to qualitatively and quantitatively feel better. And so
Yeah.
we build a plan around what they want. And then we just like get to work, start digging. And I think a word for your listeners, it can feel so frustrating when you go to like doctor to doctor to doctor. No one has an answer. They've done scopes and scans and labs, and they say, oh, great, everything's normal. You must be fine. Or even worse, this is clearly just anxiety. That's all this really is.
Oh God.
Um,
Yeah.
yes. So for people to be believed and to be able to curate a plan around what really matters most to them, I think is incredibly empowering. And so that's the fun part of my job, is to help people feel better.
Yeah, and that initial conversation is key.
Mm,
I have a similar conversation, when you look at someone's track record, all the specialists that they've been to, and now, at least especially for me in the surgical space, they come to me thinking that I am going to mechanically fix it, right?
yeah.
That I
Yeah.
am going to nip tuck remove transform. And so I oftentimes tell them like, hey, number one, I know you're probably at your wits end. A
Hmm.
lot of things that we're going to do is going to be a little bit of reinventing the wheel, because it's a collaborative effort, but also the things that you've tried before sometimes, um, people will do things in isolation, right? So,
Yeah.
okay, this didn't work, so I want to switch and do this. And sometimes
Yeah.
you have to stick with that
Yeah.
and then add something else on, right?
Yes. Hmm.
Um, but then also, I also ask, what is, if there was one or two things that through this process we could make better or change or treat, what would that be? Because
Hmm.
I'll tell you, we may not be able to make it perfect. So what's going to give you quality of life? But then I also say like, hey, we're going to have these conversations. I may order some additional tests and labs and this and that. And there, we may need surgery and we may not.
Hmm.
Okay. So,
Hmm.
we have to have, and I think, a lot of those things are important to establish up front, um, because, patients, again, they need to, especially in this day and age, their trust has to be restored
Yeah.
in the person that's in front of them.
Yep.
And you wouldn't even, well, I know you would believe the things that some physicians say to patients. I'm just
Yeah. It is
how'd that even come
heartbreaking.
out of your, like, it's
Yeah.
like, so I think there's also power in, again, being that to some degree therapist, that just that ear that will like listen to them. And so some of them are just like, I know you may not be able to fix me, but if you can tell me like this is something, I'm okay with knowing this
Yeah.
is actually
Yes.
something. Yeah.
Yes. Yeah. What are some of the diseases that run in that family? Like the ones that no one has believed them, that you're like, no, this is real, or this is your diagnosis that everyone missed. Like what are some
Oh,
of the things in
so
the colorectal world?
so yeah, one of the best ones is like pruritus ani, really, the itchy
Hmm.
anus. I'm like,
Hmm.
there's literally a Latin term on it. There's a pamphlet about it. Now, that really, the term really just describes your symptom, what you're experiencing. But there's a reason behind it. So it could be skin sensitivities. And so people are so fixated on the butt and they try to make it so clean. And I'm just like, the Lord made it to see poop. Okay. So it's not clean first and foremost. I was like, but so a lot of times I literally have to reinvent patients' whole thought process is like
Yeah.
literally about their butt and their anus. And I'm like, you're not going to sterilize it.
Yeah.
Um, Part of
There's
the
no way to
problem
do
is
that.
you trying to sterilize it. That's part of the
Correct.
problem, you trying to do
So
so.
interesting.
Um, but then, they forget that it's skin, just like the rest of their body. And so we have conversations about, do you have allergies or sensitivities? Do you have psoriasis? Do you have eczema? And I'm like, the skin around your anus is just like the skin on the rest of your body. So any other conditions that you battle from,
Hmm.
can happen there. And it just like kind of completely changes their mind. So that's like kind of one of the biggest ones. That's probably one of the ones that I talk to people like almost the longest about, because
Yeah.
also there's food sensitivities, right? You
Right.
tell people you eat a whole bunch of jalapenos, you feel it coming out. Well, well, there's other foods, right? That if you're
Yeah.
sensitive to or allergic to, a lot of acidic things, a lot of, other rich foods, as you pass your waist and wipe and it gets in contact with that skin, it can
Yeah.
affect that area.
That's so interesting.
Um,
Okay.
yeah, that's one of them. And then I would say the second thing is also like, and kind of and it kind of goes along with our conversation tonight when people are having pelvic floor dysfunction. So if they're having like that laxity of the pelvic floor and the rectocele and they can't really kind of push it out well, they think that they have to make the bowels softer.
Hmm.
They equate it to constipation, and so
Yeah.
they're doing all these things. I'm taking stool softeners and I'm taking
Yeah.
Miralax and I'm trying to, and I'm like, that's actually the exact opposite
Yeah.
of
Because you've
what you
like
need to
made it
do.
into soft serve ice cream. And so there's no
Yep.
bulk to like move it through,
Yep.
right? Yeah.
Yep. Or I call it toothpaste, right? So like when you're
Yeah.
trying to squeeze that last bit of toothpaste out of the tube, I'm like, so
Hmm.
you're struggling, right? And
Yeah.
so you need that bulk, you need that fiber, you need that heft because it's easier to hold a rock than mud than water. You can control
Hmm.
that better. And so once I start giving those analogies, then that's
Yeah.
when we can kind of reframe the conversation about the pelvic floor because they get obsessed with trying to make it soft to go, and that's not always, the right answer. Yeah.
This is what I love about having these types of conversations with our colleagues. One of the fun parts of owning my own practice is that I've actually gone and shadowed a bunch of different specialists to just like
Mhm.
see what they do for better understanding and learn. And that rock and mud and water analogy is just, it's like so spot on. It's like accessible. You don't need a medical degree to understand it. I'm stealing that one. Thank you for that.
You can have it. You can have it.
Thank you. Appreciate it.
Um, so what is your like, I guess, most fun disorder to treat?
Oh my God. Well, basically I create a whole practice around them. I mean, that is it.
Yep.
It's I mean, I can't think of a better practice because I get to be a super nerd, which is I get to learn, I get to get curious, I get to ask 1,000 different questions. I get to put together all the pieces of the puzzle. I figure out which ones don't fit, which ones do. I get to teach, which I always thought I was going to stay in academic medicine. So teaching is a super fun part of that,
Mhm.
not just for patients, but I do a lot of education for other clinicians to help understand this stuff. Because with deep respect for our colleagues, we are a little slow to learn this area of medicine, and therapists and dietitians and physical therapists tend to be really seeing a lot of these patients that I take care of. The most fun? I mean, I don't know. I think I really like all of them because everyone is just like slightly different. And like the Venn diagram beyond the POTS, EDS, and mast cell disease, there's a heavy degree of overlap with neurodiversity. And so my patients are like brilliant, change the world kind of people. That's really, you asked about my why earlier. That is my why. Like, I know that if I can relieve people's suffering by 10%, 50%, 75%, 100 would be great. They truly will change the world. They look at the world in a totally different way. And
Yeah.
anyway, I just love the people that I take care of. And I think that's what it comes back to is just really being able to like relieve suffering, but to get to know people and like the really fascinating ways that they live their life and what they do and who they are. So it's fun to get to know people over time.
Yeah.
Yeah. And I like the diagnostic part of things, like the rule in and rule out. That's what we're trained to do as internists. I'll joke as was telling a friend recently about, when I was back in med school, the last time I was actually pretending to be a surgeon was many, many, many years ago. But I was just like, it was so boring. I would just stand there and retract because that's what you do as a med student. And people would be like, wow, the appendix is inflamed. And I was like, I know, I told you that like 6 hours ago when I did the whole workup, like not to minimize my surgical colleagues by any stretch, but I was just like, I like the process of like doing the testing. It's so fun for me. So I'll hand that off to experts like you to actually use your hands and your brain. I just have my brain. So anyway, I don't know. I like all of it. It's super fun.
Yeah. Awesome, awesome. Yeah, it's funny. I feel like how you were saying like, dealing with some of the neurodivergent folks and just kind of watching them change the world. I like
Hmm.
watching my patients then go in turn and become more open and free with the
Hmm.
conversations we have because now they're relaxed. I'm like, because they come in, they're like, they're talking like this, they don't
Hmm.
want to talk about it and they're like embarrassed to
Yeah.
see and they're always apologizing like,
Yeah.
oh my God, like I tried to poop before, I tried to wipe, I tried to clean. Well, this might be the worst you've ever seen. And I'm like, well, do you really have to
Girl,
look at? I'm
no.
like, listen, I'm like, go to that waiting room. I was like, I've seen every butt out there, okay? And maybe twice or three times. So they start cracking up. I'm just like, or I'm like, I don't even recognize you all by your face. Like, bend over, maybe I know who you are.
Yeah.
So, but but I love to see once folks have broken out of their shell because they realize
Yeah.
that they aren't the only one. Like, I'll hand them a pamphlet on something. I'm like, see, it's so common. There's a pamphlet about it here. And they're like, they, their world is rocked that, oh my God, I thought, I was the only one that was, suffering from this. And so watching them then in turn go and share with their friends and their family members,
Yeah.
especially, I see a lot of, older women who may, have lost several family members and they're really
Yeah.
leaning on their friend circle, their, church member circle and things like
Yeah.
that. And so for them to then go forward and kind of pay it forward is really, they're like, I told everybody to come over here. And I'm like, yes, yes, Miss Johnson, thank you. Come on. Tell them to keep coming.
Yeah.
Um,
And I just
so
love
I'm
that.
gonna,
I mean, I don't think you can be, really uptight and be a colorectal surgeon. I think you have to have a good sense of humor. But for something that feels that people I'm sure carry a lot of shame for, they're like really embarrassed to talk about. It's not like you're talking about your high blood pressure or your diabetes, like no one's going to show up at a dinner and talk about their poop, or very few
right.
anyway. So for you to just make it so accessible and like, yeah, of course, I see I've seen all the
Right.
butts in the waiting room. I just think it's like
Yeah.
a really beautiful way for people to just be like, I feel safe because
Yeah.
it is so vulnerable being a patient. It's so vulnerable to have a problem that feels like tricky to talk about. You may not have the language. And so they're just really lucky to have you and that you can just make it feel as easy as possible.
Well, thanks. Thanks. So I'm going to take a quick pause and just check in with Sonia to see any questions that have popped in through the chat just yet while we're here live with Dr. Pepper, my
Yes,
spicy friend.
yes. There actually is a really good question that came in. What's something that maybe women are doing in the name of wellness that may actually be making their gut or hormones or overall health worse?
I'll let you start with that one.
Yeah, like the first thing that comes to mind is just when people have GI symptoms, often the things that we have access to are within our control is food. And so, like I mentioned, I got into this work as an eating disorder doctor. And so, very often, people are trying to feel better. And so, they start either eliminating foods or adding in foods or having really extreme dieting. There's a term called orthorexia where they're trying to, you may hear the words eat clean. which I'm like, the only way to eat clean is to wash your food. Like, there's no such thing as clean foods. But anyway, it's a different conversation. So people start to try to feel better by like really restricting their diet. And when people are hungry, a hungry brain is an anxious brain. And so that can drive some more like mental health issues around anxiety and OCD. And before you know it, you're off to the races, often with eating disorder behavior, or on that spectrum. And so, in the name of wellness and a sincere effort to try to feel better, a lot of times the diets that are prescribed by physicians who are not screening for eating disorders, or in a well-intentioned way, saying, oh, just cut out dairy and cut out gluten and cut out, et cetera. Before you know it, people have a true medical diagnosis of an eating disorder, which is the most lethal mental health disorder behind overdose of opiates. And so it's not a small problem, and my practice is full with a waiting list of folks who have tried their best to manage their medical problems with food. So I think that's the tricky part, and why I work hand in hand with so many dietitians who understand this, of how do we honor and address the real symptoms that you're having without going off the edge of a cliff, with a really restrictive process. And there's no absence, as we all know, of wellness influencers who are like, what I eat in a day videos, which drives me freaking crazy, because
Right.
there is
Which they ate it
no
for 5 minutes and then they're over there slamming that pizza. But anyway, um,
correct, or it's just a wellness influencer prescribed eating disorder diet. I mean, the truth is, there when people ask what is the best diet, there isn't a best diet. It's what is the problem we're trying to solve, and what are we trying, and what are the tools, and how does your body respond to that. And I think for folks who struggle with mast cell disease, they often have a lot of food sensitivities, and so they have been trying for a long time to tease out what is the food that's actually driving my symptoms. And it can feel very scary to add foods back in. I'm worried I'm going to have an allergic reaction. I'm worried I'm going to have GI distress. And so diet culture is a huge
yeah,
part of what we address in the
yeah.
practice.
And I think, and that's, so important. Again, we just recently added on nutritional services to my practice. There's a
Mhm.
registered dietitian that's with us a
That's
couple of
awesome.
days a month. So you can send them my way too. Um, Uh, but yeah, so we get no training on nutrition, like maybe a
Yeah.
day
Yeah.
during medical school. And what do you say? Eat more fiber, drink more water, all these things. But you know, everybody, as you said, everybody's a little bit different. Our
Hmm.
gut, our GI tract is one of like the largest portions of our immune system, period. And so once it's been triggered, there are certain things that can cause continued problems and issues. And then again, people will try to, in general, okay, I'm going to give up dairy, I'm going to give up that, not really realizing that there's sometimes even micro components, micro
Hmm.
ingredients within, what you're eating that
That's
may
right.
be your symptom. You can be allergic to eggs, you can be allergic to the egg white and not the yolk. And,
Mm-hmm.
so I mean, so it's so nuanced. And so that's where registered dietitians and nutritionists, play a huge role with being able to guide patients and understand their symptoms, guiding them through that, food slash symptom diary.
Right.
And then also, people have different medications,
Hmm.
people have had different surgeries, people have different medical conditions. But then it's so particular when we talk about foods and fresh fruits and veggies. The level of ripeness of a particular item can play a role in how your body. So a
100%.
lot of
Hmm.
the low FODMAP diet, right? A fresh banana that's more greenish and yellowish is, on the low FODMAP diet, but as it continues to mature and it gets more brown and much, much more sweet, it's kind of out of the low FODMAP window.
Yeah.
So there's a lot of different things that, that need to be understood before people just jump, full-fledged down ahead, whatever diet path that they're on.
Yeah.
So,
That's exactly right.
so to answer the question that just came in, I think that's kind of the most important thing right now is just kind of really understanding the limitations of what you have access to and really seek expert guidance and help with whatever you're trying to do to be well, because it can be very particular to your medical history and you can do harm if you are just going down the wrong path. Yeah.
Yeah, and I mean, certainly I hear people on in the social media realms, patients specifically saying, it's so frustrating. My doctor got no education in nutrition, and I agree. It's like a basic primitive thing that we should get more education on, and that's also why registered dietitians is its entire degree in and of itself. It is so complex. It requires a lot of training. And so, health insurance excess aside, I really believe everyone should have access to a dietitian where they can run these questions by them. And so they can get the support they need because everyone's a little different, which is cool.
Yep. Yep.
Awesome.
Any more
Awesome.
questions, Sonia?
Yes, there is one question here for Dr. Pepper. How do you know, Dr. Pepper, when gut issues are really about food and when they may actually be connected to stress, control, or maybe even a more complicated relationship with eating?
Yeah, so it requires time and questions to try to tease that out. So I mentioned that I started as a eating disorder doctor, and the practice evolved into this other space. And like I mentioned, people are trying to solve physical body problems with augmenting what their food is. It is a spectrum. So I always put my husband on one end of the spectrum. You could put him through any type of diet. Like, he just does not have an eating disorder brain. He's like a non kind of addictive brain kind of person. He's just like, food is whatever. I'll just eat it and keep it rolling. Like, he would not trigger any abnormal behaviors in him versus people who develop patterns of eating that can either be obsessive, that can be overeating, it can be undereating, it can be related to body image and a desire for thinness. It can be related to sensory issues. Like I mentioned, neurodiversity is huge in my practice. So people have physical sensory issues as they're eating. And so it requires just like asking a lot of questions. And I mean, they're none of them are particularly complicated. I'll ask, like, tell me about your relationship with food, with your body, with exercise. What happens? Like, walk me through when you put this thing in your mouth. What is the sensory experience? Mechanically, what's happening? What are you feeling in your body? Are you having pain, bloating? How are you moving your bowels? Um, and there's obviously like formal eating disorder questionnaires that you can ask, but ultimately it's about teasing out some of those things and looking at the bigger picture. And like I said earlier, I joke about how I'm a gastroenterologist. I mean, even in eating disorder recovery, I mean, probably 90% of what I'm doing is talking about the gut and motility, um, because your gut is lined with muscle. So, it's the thing that makes the food move down the tube. And so, if you have not been eating enough and you have been
Mhm.
starving, when you start eating again, it's like going to the gym for the first time and picking up a 100-pound dumbbell. It's sore, it hurts, it's hard to do. And so, we have to like gradually work with the gut to get it moving again. We've got to build up those muscles. Um, so there's a whole field of eating disorder medicine and certification, but therapists, dietitians, and then certainly clinicians like primary care docs or psychiatrists, et cetera, can get certified in eating disorder care. But it requires asking the right questions. And it becomes pretty obvious once you've been doing this for long enough. And the part that I think is really interesting is that no one wants to have an eating disorder. I mean, I would not wish this on my worst enemy, but I really enjoy the mental and the physical aspect of that. Like, what part is true physical body stuff, and what is the part where the brain is playing tricks on us?
Yeah. Yeah. And I a lot of times will see the folks on the other side of that spectrum when we were talking about having those conversations about
Hmm.
the muscles within the gastrointestinal tract. I did see a lot of patients, kind of in that post-COVID or now this era where there's a lot of working remote, and so people may not be as physically active, and
Hmm.
so now they're coming to see me for chronic constipation or what has now become chronic constipation, and they're like, "Man, I used to be so regular," or whatever, blah blah blah. So then you start asking, when did the constipation start or whatever,
Hmm.
blah, blah, blah. I'm like, okay, what happened around then? You're like, oh, you transitioned from, going into the office to now you're sitting at home at a desk all day. So you're not physically active. Well, your muscles aren't getting blood flow. And so they can't squeeze and propel your waist forward. So
Yep.
the top three things when we talk about gut motility before we start going down stool softener and Miralax and fiber path is drinking enough water. Got
Hmm.
another analogy for you that you can steal.
Oh,
Um,
thanks. Yeah, I'm listening.
So toilet bowl, right? Right? If you go poop in the toilet bowl and flush the handle and there's no water in the tank, what happens?
Okay.
It
Okay. Yeah,
sits there. So you
those
have to
guys are
drink
there.
water. Yep. So drink water, putting the right food in, so your fruits, veggies, eating all the colors of the rainbow, avoiding the, ultra processed foods. And then the final thing is activity. So you
Mhm.
have to maximize those three things, because, people come, they start on that path. And they're like, oh, it didn't work. And so they go see someone and they get prescribed one of these fancy medications. And so now they're like, oh, that medication's going to work. And they stop doing all the building blocks. And I'm like, that medicine has to work on something. So if you're not eating the right things, if you're not drinking, what is the medicine doing? So yeah.
Yes, exactly.
Yep.
And this may
Mhm.
be too much information for Instagram, but there's a concept called overflow diarrhea, which is kind of
Yep.
the end product of what you're describing. The longer stool sits in your colon, it's really not moving fast, but hopefully you're still eating food from up top. So the liquid waste is coming down the pipelines, runs into the stool, and kind of overflows around it. Sorry if that's too much for your listeners.
Nope. It came
But
up last
often people,
conversation with I can't even remember. It's gonna escape me now. It'll come back. But yeah, we had a recent conversation about that. Yep.
yes. So some people who are like, food just goes right through me and comes out as liquid. That's always a cue to me. That's actually probably not diarrhea. It's actually constipation. Anyway, side
Yep.
note. Fun
Yep,
fact.
yep. Or overflowing continents. That's kind of what we
Yeah.
talked about again, like
Yeah.
that overflow continent. So combination of that, like they're I'm constipated, but then all of a sudden I'm pooping on myself, but it's liquid. I'm like, yeah, it's your body has to try to snake its way around that. So yeah. Any other questions in the chat?
Yeah, yeah. This is such a good conversation. So many gems being dropped by you ladies. Thank you so much for this. Um, One other question is, can mast cell activation syndrome be diagnosed through an upper endoscopy? And if so, what testing would be done on the biopsy?
Okay, so you're wading into deep waters. It's like we were taught, you can, there's only certain topics you're allowed to talk about, at the dinner table. And so the mast cell activation syndrome diagnoses is like a highly contentious, well, it's polarizing. That's probably a better word. So if you want the Quad AI, the American Association of Allergy, Asthma, and Immunology, oh, got it. They released guidelines back in 2019. About what is mast cell and what it is not. And if you take all folks who have mast cell symptoms and run them through their criteria, only about 2% of people are going to meet criteria for MCAS. It's, in short, you have symptoms that are suggestive of mast cell disease, you check blood work or you check blood work and for specific um, chemicals in the blood and they're positive, and they show an increase during symptoms. Three, you treat them for MCAS and they get better. And then there's this genetic test that you do called the KIT mutation afterwards. Um, it's important to note that in order to have those blood work tests turn positive, the best time to do it is after an episode of anaphylaxis. You go to the lab within 30 to 90 minutes. They draw your blood, they cool it in a centrifuge, spin it, and then process it immediately. Like, real talk. Do you think that ever happens? Never. And so the labs are notoriously unreliable and really hard to find a positive test because, the chemical they're looking for is unstable. And so often patients are told, well, you don't have mast cell disease. And while technically they may not meet those current criteria, it's interesting in the paper, it says at the very top, these guidelines are only good for 5 years. Note that it was written back in 2019. And secondly, these should not replace clinical judgment. And so I think of mast cell disease as a spectrum disorder. There, it ranges from like a overproduction of mast cells in the bone marrow all the way to when people are having a lot of symptoms and they're improving on these low risk therapies, but they don't quite meet criteria. So it's a long way of saying the ideal way is through blood tests, which is very hard to get. So there's some surrogate markers that people will look at, which is um, histamine, tryptase, leukotrienes, prostaglandins, chromogranin. Some people will use urine histamine levels. But to answer your question directly, you can stain tissues, particularly in the GI tract, for mast cells themselves. So the gastroenterologist or colorectal person will do a biopsy, send that tissue to the pathologist. They stain it with a test called CD117 that stains for mast cells specifically. And then the pathologist can count those cells under the microscope. There's no consensus about what is the right number of mast cells to qualify as a diagnosis in the stomach and small intestine. The average number of mast cells that a normal person would have is around 20. I don't know the count in the colon. You may. I don't know if you know that number either.
Ooh, I don't off
r-
the top of my head.
Roughly 20.
Yeah.
Um, but I've had a patient come back with, because there's no consensus guidelines, I had a patient come back with a path report that said 90 mast cells per high powered field, which is like rip roaring mast cell disease. But the pathologist said no evidence of mast cell activation syndrome, which is technically correct, because, but it doesn't look at the clinical picture. So
Right.
to answer your listener's question, can you diagnose it through EGD? Not according to the Quad AI guidelines, but anyone who takes care of mast cell disease would be like, this is like really, really helpful diagnostic criteria. So I encourage our gastroenterology friends to do the stain because it gives us a clue in a diagnosis that's really challenging to make.
Yeah. Thanks for that. And I think it's very akin to, some of the conversations that we have about, gluten sensitivity and celiac, right?
Hmm.
There's the true allergy.
Yes,
Gluten is a protein. So there's a true allergy, but then there's the sensitivity, right? Your body
that's
has
right.
to break it down. And so if you overwhelm, it's like drinking, you can people have a different level of tolerance to your body, the enzymes in your body that's supposed to break down the alcohol. If it doesn't move fast enough, you get drunk, right? And so, kind
Right.
of same thing, with gluten sensitivity. If you overwhelm your system, you may start experiencing symptoms associated with gluten consumption, but it may be that you just overwhelmed your gut. It's not that you are allergic to it. So,
Yeah, that's exactly
yeah,
right. And I think the analogy I often give patients is like blood pressure, right? You can have low blood pressure, you can have normal blood pressure, you can have high blood pressure. And
mhm,
we've assigned, frankly, it's related to cardiovascular risk, but like a line in the sand to say when you go from normal to high blood pressure. But in reality, it's a spectrum, just like
yep,
blood sugar is a spectrum. It can be low, it can be normal, it can be high. And so, for a lot of the diseases that end up in my clinic, whether it's eating disorder behavior or it's mast cell disease or it's POTS, it's a spectrum. We have a line in the sand where we say this is a yes diagnosis. But I have so many people who are like towing the line. They technically
yep,
don't meet criteria, but I'm not going to be like, sorry, I can't treat you. I'm like, you deserve to have some treatment that relieves your symptoms, even if the diagnosis in the chart is like orthostatic intolerance instead of POTS, or disordered eating, but you don't have an eating disorder. And in the mast cell world, it's like histamine sensitivity, but we don't have a diagnosis code for that. Like mast cell spectrum disorder, we don't have a diagnosis for that. So sometimes I just call it like rash because that's their symptom. So I think, listen, I love Western medicine. It's an incredible privilege to be able to do this work and take care of people. And our guidelines, like we can crack people's chest open and like put in new organs. It is like nothing short of miraculous what has been achieved through science. But if you don't fit in that box, it doesn't mean you
yeah,
don't have a problem. It just means you don't meet our current diagnostic criteria, which there's going to be a lag time for. So I think for anyone who's struggling to advocate for their help, finding a doc or a clinician of any type that you can like partner with, they
yep.
often know what are the other people in this circle, and they can kind of get you to the other clinicians that enjoy taking care of this subset of illnesses and are able to help you.
Yeah. Um, so we're going to start wrapping up shortly. Sonia, save those questions. You can share them with Dr. Pepper and I, and we can actually post some videos to answer those final questions that come through. But the one last thing that I really want to tackle, because as I put out the little teaser for tonight, I said, that tonight will be important for both patients and physicians alike.
Yeah.
So we talked a little bit about us being twinsies, spending several years in medicine and then, finding learning more and more about ourselves in our prior employed positions, but also as we started our own practices over the time and of development of that, shifting our focus within our practice because of the
Yeah.
patients that we were taking care of.
Yeah.
So with you, some of the complex medical disorders, the invisible diseases, Ehlers-Danlos, and the mast cell diseases, and for me, a lot of pelvic floor and functional health.
Mhm.
So, I want to just take a brief moment to speak specifically to any professionals that may
Mhm.
be watching today. So you could be a physician, you could be a business, you can be whatever. You may be at a point where you're kind of struggling with your current employed situation or just kind of what has been defined as you doing your work. And so I want to just ask you to briefly touch on like what kind of really made you have the confidence or that first step to kind of break out of what you had been trained to do for so long to kind of, kind of create your own path forward.
I think there's probably several key factors to that. I would be remiss if I didn't just say burnout was a part of it. Uh, as you know, a new grad for medicine, I thought I would have a 30-year ahead of me, and as burnout kind of set in, I'd be like, okay, maybe it's closer to 20 years. And then by the time the pandemic came around, and I was profoundly frustrated with many things, but particularly as it related to my previous job, I was looking at my career thinking like, I'm not sure I can do this for another year or two. And I still knew I liked practicing medicine. I just knew I didn't want to do it that way. And so it was not confidence, it was desperation, pure and simple, to say, like, I've got to
Mhm.
jump. The analogy I'd heard from someone else was like, I'm in a burning building and I will either jump and create a safe place to land, or I will crash and burn. But either way, I'm not dying in this building. And I know that may sound dramatic, but that's really, it was desperation. I needed to leave. And I gave myself some time to heal and really kind of came back to, like, I mean, obviously, I think I love my job. And I think that's obvious in how we've talked about this today. So that's one. You don't have to wait for confidence, because for so many of us, especially women, imposter syndrome is a big part of that. And I spent so much of my career thinking, this ideal of the eternally confident physician who had absolutes and knew how everything was going to turn out. And they're like, I can fix this. That never really resonated with me. I always thought, like, well, what if? What if? And like, there's different ways that this could turn out. And like, actually, what patients are telling me is not consistent with the guidelines, or not consistent with what I was taught. And so I thought I was doing it wrong by listening to my patients. And so I think coming back home to like what we really enjoy and listening to the person in front of you and using our critical thinking skills, which is really what we're trying to do, was wildly helpful. So that's part of it. And then I think, um, you know that I coach physicians to help open their private practices. And so really letting people come back home to, like, if I could just wipe the slate clean and start anew, what would that look like? What would feel good? What would be fun? What would be enjoyable? And really thinking about who you love serving. And that's really a foundation for building something. The last comment I'll say about that is, like, listen, like, for any clinician, anyone working in healthcare, people are alive and well on this planet because you were the med student, the resident, the fellow, the attending in the room. Like, you have paid your moral debt, if that is really a thing. People are here. You don't need to see another patient for the rest of your life to know that you've made an impact in this world. And everything you do from here forward is by choice.
Yep.
Your debt is paid, even if your student loans are not. So you can
Right.
choose, like, stay in your current job if it's what you want to do and you like your reasons for staying. Awesome, stay. Leave if you want to leave, because you can choose what you do moving forward. And so I think getting people out of learned helplessness is a big part of finding career satisfaction, because once you know you're doing it by choice, the return of autonomy is
Yeah.
wildly compelling. Anyway, it's a long answer. What do you think?
No, no,
What
no.
made you
Th-
flip?
So it's funny. Literally, I just posted on LinkedIn either earlier this week or last week, um, for physicians. Just because you're good at something doesn't mean you have to do it.
That's exactly right. That's
Doesn't
exactly
mean you
right.
have to do it. And so I think we get to the point where, and again, you talk about people these days that are like either leaving medicine or transitioning from one form of medicine to another. And, the world is so large, but everybody needs help in their own way.
Yes.
And so just because, like, when I was in medical school, there was actually one of my classmates who was there, and he knew he was not going to practice medicine.
Hmm.
He was getting an MD, MBA, and he
Hmm.
only had intentions. He never was going to residency. He wasn't going to apply for residency. He was only there so that he could strengthen. He wanted to get into kind of healthcare business, that
Hmm.
aspect. So he knew from the beginning that he was going to be a doctor, but not practicing medicine.
Yeah.
Um, and so as we all are in a position where we are seeing, um, other persons take over the practice of medicine and the culture of medicine, I think we're going to see more and more patients and colleagues looking for people like us to
Hmm.
collaborate with and to care for us and our loved ones,
Yeah.
because we're on a certain side of medicine, that others may not see. And I think, a lot of the things that you mentioned as far as for your transition, was. It probably played a lot of the same exact kind of process in me. And back then, when I first kind of made the decision, and again, it was desperation. It was just like, when you get to the point where you're like literally having a visceral reaction driving into work,
Hmm.
that's a sign.
Yeah.
And so you have to figure out like, am I going to drive somewhere else to do the same thing or not? Or if I jumping ship on medicine, kind of
Yeah.
altogether. And so yeah, just taking that break and then understanding what aspects of your life or training or what got you to that point is like very important, but also then understanding what patients do you care about and
Hmm.
what do you get the most positive feedback and positive reinforcement from, and and just kind of making those decisions and walking that path that way. But I think it's also important to understand that the person you are today at this moment doesn't necessarily mean that's the same person that you're going to be
Amen.
next month, next
Amen.
year. We grow and develop, we change, we have family changes, we have medical conditions, other people in our lives have medical conditions that impact us. And so we just have to be able to be flexible and kind of listen to all of that and take heed and,
Yeah, we are
yeah,
whole people. And I often will point to my husband who's not in medicine. When he finished his MBA, if he was still working the same job that he did at age 27, people would think there's something wrong with him. Like, are you still the same person? Do you have no
right.
ambition? Have you not learned anything? Do you not
Yep.
want more? Like, no one in business is expected to stay in their initial role, the job they take out of school for 30 years. They're expected to evolve. And so, this idea that physicians need to do the same thing for the rest of their life. And like, God bless people who just want to show up and be the worker bee and like just replace 5,000 knees a year or, take good care of people in the primary care clinics. Great. But I think we are trained to be creative, curious people. And so nothing is going wrong if you decide you want to pivot your career. It's actually a sign of
Yep.
growth and not a sign of failure. Like, it's
Yep.
okay.
Yep. And just even dealing with, as a surgeon dealing with colorectal cancer, right? Yeah, I set up a patient, we've done all the workup, the evaluation. You get in, you plan like, hey, we're just gonna take it out, we're gonna put things back together, and we're gonna be good. And then you get in there and you find out there's signs of cancer in multiple places that didn't show up on the scans.
Mhm.
Critical fail if you proceed without, aborting probably what you initially thought was your
Yeah.
path forward in
Yes.
caring for that
Yeah.
patient. Same thing for your life, with your career and your jobs. So you
Good
have to know,
analogy.
got to know when to hold them, got to know when to fold them, as they say. So,
Yeah.
yeah,
I love that analogy. Yeah, I mean, that's
yeah,
really relatable. Like any surgeon knows, like that's part of your training is to be like, this is not working. What is my next best alternative? What's the most appropriate thing to do? And sometimes that's to walk away and like, well, I can't want you to apply that to our careers. Anyway, that's beautiful. I love that.
yeah.
Another one I'm stealing. Thank you so much. Just dropping all these.
Halvesies, halvesies. So we are coming up on that hour mark, and we usually do about 45 minutes, but this has been like just such an amazing conversation because
Yeah.
again, there was so much that twinsies that we've been through, I think, together,
Hmm.
as people, as clinicians, as physicians, as family members, wives, sisters, daughters, mothers, kind of all of that stuff. So I wanted to make sure that we kind of packed in as much as we can today.
Yeah.
Um, so thanks everybody for joining this episode of The Love Below with Dr. Kara Pepper. So give us, before we sign off, just maybe tell us the name of your practice, how people can find you, especially those who are battling with a lot of these invisible um, illnesses that no one knows anything about, or they're being gaslit and all that good stuff.
Yeah, if you remember my name, you can find me. I'm very accessible. So Kara Pepper, Kara with a K, Kara Pepper MD is my handle on all social media. My website's karapeppermd.com. Um, my office is in Atlanta. I'm located in Midtown. And so if you need help, just send a message through the website and we'll get you on the list and get you in as soon as we can. And then I also, am I allowed to say that YouTube on Instagram? I have a YouTube channel that's just a ton of patient information on exactly these topics that we're talking about. So just search Care Pepper MD over there and stay in touch. Always happy to help.
Awesome. Perfect. All right, guys. Well, next week, we haven't officially decided yet because I'm headed off next week to the National Colorectal Society. So depending on life, we'll see if we'll have another guest or if we need to pause the Love Below at least for 1 week so we can go get my CMEs. So thanks so much, everybody, for joining us tonight. I'm signing off. Dr. Tushy Touchup, Dr. Erin King-Mullins. Bye for
Thank
now.
you. Bye.